non-dilated left ventricle, often with a normal or near normal left ventricular ejection fraction. And as I said earlier, is the least common of the three clinically recognized and described cardiomyopathies. And accounts for approximately about 5% of all cases of diagnosed cardiomyopathies. Then it's worthy of note to take note that the predominant manifestation is diastolic dysfunction, actually due to the stiffness of the myocardial wall. Now, restrictive cardiomyopathy could also be defined as restrictive left and or right ventricular pathophysiology in the presence of normal or reduced diastolic volumes of one or both ventricles, then normal or reduced systolic volumes, and then normal ventricular wall thickness. Now, restrictive cardiomyopathy commonly presents as bilateral enlargement, and majorly that's because of the impaired left ventricular filling during diastole. Most times, the left ventricular systolic function could be preserved, but in some cases, especially in the cases of patients with sarcoid cardiomyopathy, they could actually have systolic dysfunction. Now, restrictive pathophysiology may not be present throughout the natural history, but only at the initial stage. But with time, it could actually deteriorate. Now, there are other conditions that could actually have this impaired filling abnormality, or that's diastolic abnormality. You can see it in patients with hypertensive heart disease, aortic stenosis, end-stage hypertrophic cardiomyopathies, endocardial diseases. Those are some of the diseases that could also give a restrictive ventricular pathophysiology. Now, we look at the course of restrictive cardiomyopathy. It actually varies depending on the pathology and treatment. And it's been found to be a significant cause of heart failure with preserved ejection fraction, except for probably maybe like typhoid, those infiltrative cardiomyopathies, which could actually cause systolic dysfunction. Sometimes there could also be an overlap between right cardiomyopathy and hypertrophic cardiomyopathy. Then making
what are the possible causes? See how will you investigate?
Hello?
You can proceed. Yes, you're being heard.
So moving forward, making diagnosis of restrictive cardiomyopathies is still very challenging, considering the need to utilize several modalities of investigation in order to arrive at the final diagnosis. An endomyocardial biopsy plays a very key role in actually making a diagnosis of specific causes of restrictive cardiomyopathy, especially when it comes to the infiltrative cardiomyopathies. And then cardiac magnetic resonance imaging with T1 or T2 has also helped to increase the diagnostic yield and then also reduce the need for endomyocardial biopsy. Then when a cause of restrictive cardiomyopathy could not be identified, is actually termed an idiopathic restrictive cardiomyopathy. And then there has also been the familial type, yes. And then genetic testing is now indicated for any cause of restrictive cardiomyopathy where the etiology is uncertain or unknown, even when the family history is negative. Now, when we look at the familial restrictive cardiomyopathy, it's actually 30% of the cases of restrictive cardiomyopathy are said to be familial. And some of the genes that have been linked to these are: one, we have the sarcomeric, which is autosomal dominant inheritance. We have the DES, that's the desmin, which is both autosomal dominant and autosomal recessive. Then we have the FLNC, those are the flamin, autosomal dominant. And then we have the BAG3, BAG3, autosomal dominant. And then we have the rasopathies, which are linked with some syndromes, like Noonan syndrome, like Legion syndrome. Those ones actually have either autosomal dominant or autosomal recessive. Looking at the epidemiology, restrictive cardiomyopathy is actually very rare in adults, but they said the incidence in children is about 0.003%. Reference that from European Society of Cardiology 2023 cardiomyopathies. Now, both male and female are affected equally, especially when it comes to the idiopathic type. And then the idiopathic type is seen primarily in the United States. Now, when we look at the endomyocardial fibrosis type, which is the one that is seen in the tropics, that one is seen in the tropics or subtropical, as well as Asian, southern part of America, whereas low-flow endocarditis is seen in the temperate area and has predilection for young males. Now, the EMF, that's the endomyocardial fibrosis, occurs most commonly in Uganda. The first reported case was actually reported in Uganda, and then it's said to account for about 25% of deaths from heart failure in this tropical area. Now, going to the classification of restrictive cardiomyopathy, it can be classified based on whether it is a local disorder or systemic disorder. It could also be classified as either idiopathic or primary, or familiar or secondary. I talked about the familiar when there are some genetic some genes that have been linked to that. And if it's acquired, you could have amyloidosis and myocardial diseases with or without hyperosinophenia. But most of the causes of restrictive cardiomyopathy are actually acquired. Now, you could also classify it based on the pathologic findings, whereby it's classified as either obliterative or non-obliterative. Obliterative just means that there's a thrombus within the ventricle, which is causing an obstruction. And the obliterative type is actually very rare. And it may actually result from the end stage of the eosinophilic syndrome, talking about the alpha-eosinophilic syndrome, low-flow endocarditis. But for the non-obliterative, that one is seen in the idiopathic restrictive cardiomyopathy. Could also be seen in the radiation-associated restrictive cardiomyopathy. Those are some of the causes of non-obliterative and restrictive cardiomyopathy. Now, this is just a table just showing up, or probably diagram just showing another way you can classify restrictive cardiomyopathy. It can be classified as myocardial and then endomyocardial. Now, for the myocardial, you can sub-classify it further to non-infiltrative cardiomyopathies, where you have the idiopathic, familiar, pseudoxanthoma, elasticum, then scleroderma, systemic sclerosis. Then two infiltrative cardiomyopathies, where you have amyloidosis, sarcoidosis. Then thirdly, under the myocardial, we have the storage disease, the hemochromatosis, Gaucher's disease, Fabry disease, and some other glycogen storage diseases. Then for the other part, that's the endomyocardial. That's where we talk about the obliterative or non-obliterative. Then the obliterative are the EMF, and then the HES, that's the eosinophilic syndrome. Whereas under the non-obliterative, we have the carcinoid heart disease, we can have malignant infiltration, then also iatrogenic, either from radiation, as a result of radiation therapy for some cancers, and then some drugs like anthracycline. Okay, sorry. Now, talking about the pathophysiology. No, sorry. This is another way you can also classify. Restrictive cardiomyopathy based on the therapy approach. One, intrinsic, we can classify, we could have one as intrinsic myocardial dysfunction or interstitial fibrosis, then interstitial infiltration. Example of that interstitial infiltration is like sarcoidosis, amyloidosis. Then you could have cardiomyocyte accumulation of storage materials, like in the cases of when you have Gaucher's disease, Pompe's disease, and other storage disorders. Then lastly, endomyocardial diseases, where you have endomyocardial fibrosis, low-flow endocarditis. Okay. When I classified earlier, I talked about we could have idiopathic, idiopathic or primary, then familiar and secondary. So under the primary, we have the idiopathic EMF, low-flow, and in secondary, you have these causes that are listed here. Now, going to the pathophysiology. Now, the major thing there is for restrictive cardiomyopathy is that there is increased stiffness of the ventricles. it could affect either the left ventricle alone, or it can affect both ventricles. So as a result of the stiffness of that wall, which is actually termed a rigid myocardium, which is actually the basis for the diastolic dysfunction in them. And this actually leads to the following. One, there is increase in the ventricular pressure during the diastolic filling phase, and also there's impaired ventricular filling, and then there's decreased ventricular wall compliance. That's the consequence of this rigid myocardium that is seen in patients with restrictive cardiomyopathy. Now, going to the first one. So when there is rigid myocardium, and then what happens when you look at what leads to the increased ventricular pressure is because of the stiffness. There is a rapid filling of the blood, and so what will happen is that there is a rapid rise in the pressure within the ventricle, and as a result of this pressure is actually transmitted to the right, leading to increased venous pressure, and then which could actually lead to right-sided heart failure, and then can manifest with hepatic congestion, hepatomegaly, ascites, elevated jugular venous pressure, and peripheral edema. Now, the other part is due to the rigidity of the myocardium, the ventricular filling could actually be affected. And then because of the restriction of the filling, this can actually affect the stroke volume, and consequently affect the cardiac output. And as a result of that, it will lead to reduced perfusion of essential organs, and then you have tissue hypoxia. So when there is tissue hypoxia affecting the skeletal muscles, that can lead to fatigue, and then the consequence of subsequent tissue hypoxia could also lead to breathlessness and tachypnea. Now, the third mechanism, the third consequence of the rigidity of the myocardium is that there's reduced left ventricular wall compliance. And at the earlier stage, the ventricle is able to fill easily at low pressure, but later, as the stiffness gets worsened, there's the compliance of the myocardium worsens, and it becomes very hard for even the ventricles to fill at all. And this could actually manifest as raised jugular venous pressure. And then the atrial contracts to push blood into the stiff ventricle, which is actually responsible for the fourth heart sound that can be picked in patients with restrictive cardiomyopathy. Okay, this is just a pictorial diagram just summarizing the pathogenesis and some of the clinical findings that can be seen in patients with restrictive cardiomyopathy. Looking at the left upper part, we have amyloidosis, sarcoidosis. They all lead to stiffening of either the left ventricle or the right ventricle, and then which is the hallmark of what leads to the diastolic dysfunction in them. And the other things I've actually spoken about through the pathophysiological process that we can actually explain some of the clinical findings that we're actually seeing in some of these patients. Now, looking at the clinical presentation, most times patients with restrictive cardiomyopathy, they don't usually present at the early stage. Most times they present when there is already the stage of advanced heart failure, and there is prominent cardiopulmonary symptoms. Then it's also very important when we're also taking history, to actually take history about the family history is also very important, as we talk about that 30% of restrictive cardiomyopathy that accounts for the familial type. Now, if patient has left-sided heart failure, they present with progressive breathlessness, effort intolerance, autopnea, fatigue. And then if they have right-sided heart failure, they present with lower limb extremity edema, hepatomegaly, which may be tender, then right hypochondrial pain and ascites. The chest pain is worthy of us to say that chest pain is very rare, but this could be seen in some of the infiltrative type, like the amyloidosis, which could actually manifest as chest pain, could be a presentation in such cases. Then you could have palpitation as a result of atrial fibrillation. Then it said about a third of patients they present with thromboembolic complications. It could present with pulmonary embolism or deep vein thrombosis. So sometimes some patients could also present with syncope or sudden cardiac death, and this is actually very common in the cardiac amyloidosis, the AL type of the cardiac amyloidosis. Now, ventricular arrhythmias, while not so common, then some patients may also have a prior history of radiation therapy. If you remember, I talked about the non-obliterated type that you could have radiation-associated restrictive cardiomyopathy. So a prior history of radiation therapy, probably for a cancer, or probably a patient that has had heart transplantation, considering that they may need to be on some chemotherapeutic drugs, or any other systemic illness are also very important as part of history that is needed to be taken in the patient. Then also, a careful physical examination is also needed to search for extracardiac manifestations, especially when it comes to infiltrative type. That's talking about the sarcoidosis, amyloidosis, or some of the storage disease. Then it's also very important to suspect cardiac amyloidosis, especially when patient comes in with easy bruisability, periorbital, purpura, microglossia, or carpal tunnel syndrome, hepatomegaly, especially when we're having infiltration of organs in the body, you're having organomegaly. That should actually prompt the suspicion for cardiac amyloidosis. Then on cardiovascular examination, patient may have a reduced pulse volume as a result of the rigidity of the myocardium. There is impaired feeling, which eventually affect the stroke volume as well as the cardiac output. Heart sound may just be 1 and 2 with the normal S2 split. And then one could actually, in patient with, one could actually pick a loud, early diastolic filling sound. And a further sound may also is almost never present in cardiac amyloidosis. Then murmur from a mitral regurgitation or tricuspid regurgitation may actually be heard, which is in the mitral and the tricuspid area. Now, some other presentation may actually give a suspicion for a particular specific cause of restrictive cardiomyopathy. For example, a patient is having learning difficulties, developmental delay. That could be a pointer to Noonan syndrome, which is actually associated with the rasopathies. Then, if a patient is having paresthesia or a sensory abnormality or sensory deficit, that could be a pointer to possibility of cardiac amyloidosis. And then when there is muscular weakness, one could think of a possibility of the spinopathies. Now, going to the evaluation, is very important that ECG is one of the very important investigations. ESC guideline talked about ESC falls as class 1 indication. Is recommended for all patients that is being suspected to have cardiomyopathy, and is actually abnormal. They have an abnormal ECG. More than 90% of patients who actually have restrictive cardiomyopathy, but in some few, the ECG may actually be normal. And some of the findings may include non-specific ST T-wave changes, low voltage QRS complexes, especially where you have a low voltage QRS complex, and then when you have you did an echo, you're having left ventricular hypertrophy, a very thickened interventricular septum. Now, it's worthy of note to state that absence of a low voltage does not exclude the diagnosis of restrictive cardiomyopathy. It's not all or none. So atrial fibrillation could be seen in up to about 74% of patients, and then could have some conduction abnormalities ranging from either a 4th-degree AV block to a very high-grade AV block. Then could also have a bundle branch blocks, either a left bundle branch block or left bundle branch block, which could be seen in any of the types of the restrictive cardiomyopathy. But when there is conduction system abnormalities, it's very important to actually entertain the possibility of infiltrative cardiomyopathies, amyloidosis, and then also sarcoidosis. Now, other investigations that are also very important is echocardiography. One could actually do a transthoracic echocardiography, then also Doppler studies, cardiac computerized tomography scan, cardiac magnetic resonance imaging, also cardiac catheterization, as well as endomyocardial biopsy. These are very important, especially when it comes to identifying the specific cause of the restrictive cardiomyopathy. Now, some lab tests are also very beneficial, especially when it comes looking at the ESC guideline for 2023. Actually categorize the lab test into two levels: the first level and the second level. Where the first level tests include the creatine kinase, ferritin, full blood count, LFTs, NT-proBNP, urinalysis, serum ACE, troponin, and so on. And then the second level talks about the organ and non-organ specific autoantibodies. Then you have the serum angiotensin converting enzyme as also part of the second level. Now, going to the treatment, just talk generally, treatment generally for restrictive cardiomyopathy before I go to the specific one. So, restrictive cardiomyopathy as of today has no specific treatment, except that therapies are directed at individual causes. So, but some therapies have been shown to be of benefit in reducing mortality, also helps to improve the prognosis in some. Then also, patient presenting with heart failure, is good to place them on guideline-directed medical therapy. And for those that have arrhythmias, either the atrial arrhythmias or ventricular arrhythmias, especially the atrial arrhythmias, amiodarone is also very important, is beneficial in them, especially because of the structural heart disease that they have. Then oral anticoagulation is very important to prevent thromboembolic events. Now, in the case of sarcoidosis as well as low-flow endocarditis, corticosteroid is actually beneficial. Then endocardiectomy is also actually beneficial in patients with endomyocardial fibrosis. Then for hemochromatosis, you have phlebotomy and chelation. Then also for cardiac amyloidosis, methylene, tafamidis is shown to be of benefit. Then also there will be need to actually give a pacemaker or as well, or plus or minus ICD, depending on the severity of the conduction system disturbance that they actually have. Then it's also worthy of note to say that it's very important to avoid digoxin in patients with amyloidosis, because it could actually worsen it. So some of the differential diagnosis, one very close differential diagnosis of restrictive cardiomyopathy is actually constrictive pericarditis, which I'll talk briefly about. Other differential diagnoses include hypertensive heart disease, any condition that could actually cause a restrictive pathophysiology is actually a very close differential diagnosis of restrictive cardiomyopathy, and these are some of the list. And then some that have thickened interventricular wall or left ventricular hypertrophy. These are also some of the close differential diagnoses of restrictive cardiomyopathy. Now, this is just a table differentiating between restrictive cardiomyopathy and constrictive pericarditis. Now, starting with the history, for the case of restrictive cardiomyopathy, one could get history of probably that could suggest amyloidosis or probably iron overload, chromatosis. Whereas in the case of constrictive pericarditis, there may be a prior issue of pericarditis or any condition that could have led to pericardial disease. Then on physical examination, Kussmaul sign may be absent in restrictive cardiomyopathy, but is usually present in constrictive pericarditis. Then one could have a prominent apical impulse in restrictive cardiomyopathy, and this is usually not palpable in constrictive pericarditis. Then there could be a presence of a third heart sound or a fourth heart sound. But in the case of constrictive pericarditis, we have pericardial knock, which is actually a high frequency sound compared to that of a third heart sound, which is actually a low frequency sound. Now, murmurs are actually common in restrictive cardiomyopathy, but they are uncommon in constrictive pericarditis. Now, for chest X-ray, restrictive cardiomyopathy may be normal or show dilatation of atrium. That's depending on the type, as well as the stage at which the disease is actually peaked. But in the case of constrictive pericarditis, we have pericardial calcification. Now, for electrocardiogram, in restrictive cardiomyopathy, you can have low voltages, you have left deviation, atrial fibrillation, AV blocks, bundle branch blocks, that the left or the right. Whereas in constrictive pericarditis, they could also have a low voltage, but they wouldn't have all this atrial fibrillation, bundle branch block, and so on. Now, for the echocardiography, now we have increased left ventricular wall thickness. That's especially the interventricular septum or interventricular septum. That's seen in amyloidosis, and sometimes because of the application of the cardiac valves, you could have thickening of the cardiac valves. And then for amyloidosis, you have this granular sparkling texture. Now, in the case of constrictive pericarditis, the walls are actually normal, but there's pericardial thickening. Then in which case the pericardium could be as thick as more than 5 millimeter, 5 centimeter. Then could have this also on echocardiography on constricted pericarditis. You can have prominent early diastolic filling with abrupt displacement of interventricular septum. When you have this septal bounce, then there could also be distended inferior vena cava. Now, for the Doppler studies, now for restrictive cardiomyopathy, the right ventricular velocity is actually reduced. Both the right and the left are actually reduced with inspiration, whereas for constrictive pericarditis, the right ventricular systolic velocity is increased, while the left ventricular systolic velocity is actually reduced with inspiration. Then you also have okay, sorry, let me just move to the next one. Now, looking at for the cardiac catheterization, for restrictive cardiomyopathy, left ventricular diastolic pressure is often greater than 5 millimeter mercury and is greater than that of the right ventricular end-diastolic pressure, whereas for the constrictive pericarditis, the pressure within the right and the left are actually equal. And then the right ventricular systolic pressure is less than 50 millimeter mercury in constrictive pericarditis. And then the right ventricular end-diastolic pressure could be greater than 1/3 of the right ventricular systolic pressure. Now, when we do endomyocardial biopsy, that may actually reveal the specific cause of restrictive cardiomyopathy, but these may actually be normal or show just non-specific myocyte hypertrophy in constrictive pericarditis. Now, for CT or computed tomography or magnetic resonance imaging, pericardium usually normal. That's for restrictive cardiomyopathy, whereas there is thickening of the pericardium in constrictive pericarditis. And then for the treatment, no specific treatment for restrictive cardiomyopathy, or except for targeted treatment towards the specific types or specific causes of restrictive cardiomyopathy. But for constrictive pericarditis, it's said to be potentially curable when it's picked early and then one does surgical pericardiectomy. Now, these are some of the complications, thromboembolism, which could be as a result of spontaneous echo contrast in the dilated atrium, could be as a result of atrial fibrillation, then cardiac dysrhythmias, cardiac cirrhosis, pulmonary hypertension, then progressive decline of cardiac function, and sometimes it could actually lead to death. Sometimes some of them could have an unexplained death as a form of complication. Now, prognosis. Restrictive cardiomyopathy has the poorest prognosis among all the types of the cardiomyopathies. Its prognosis is said to be generally poor in the adult population due to the progressive deterioration. And that's why, most times they present at a very late stage by the time it's actually identified or diagnosis actually made. And the 2-year and 5-year mortality rates said to be 50% and 75% respectively, and is also associated with the highest rate of sudden cardiac death. Then those who are refractory to supportive treatment usually die of low output heart failure unless heart transplantation is actually offered to them. Now, I'll just go take some of the different types of restrictive cardiomyopathy. I would like to start with idiopathic restrictive cardiomyopathy. The idiopathic restrictive cardiomyopathy has been described in individuals from infancy to late adulthood, and is actually said to carry a very poor prognosis, especially in children. Disease is rare. And then a reported series actually shows that only 91 cases have been seen over a period of 17 years, and that's to tell you that how very rare the disease actually is. Then symptoms of idiopathic restrictive cardiomyopathy are non-specific and reflect and could actually reflect the presence of heart failure. Dyspnea is an initial complaint in most patients, and then edema can be seen in up to about 50%. Then palpitations, fatigue, or autopnea are reported in about 22 to 33% of patients. Physical examination usually consistent with that of biventricular failure, that both the left and the right, with jugular venous distension noted in most patients. Then ascites and significant edema are usually seen in advanced cases. Atrial fibrillation is common. Then a third heart sound is actually seen in about 25% of patients. Then murmurs are not usually a feature, except for in those that actually have the low flares and endocarditis, where they have, or those that actually have infiltrative type. Those are the ones that you have more of the murmurs. Then for idiopathic restrictive cardiomyopathy, the ECG actually has a normal voltage, and which is a way of actually excluding that of a differentiating factor to that of cardiac amyloidosis. Now, talking about the idiopathic type. Now, on echocardiography, one could actually see biatrial enlargement and then non-dilated ventricles with a normal or near normal left ventricular ejection fraction, and then with left ventricular wall thickness. And then during cardiac catheterization, the right ventricle and left ventricular filling pressure are elevated with a dip and a plateau tracing often seen, unlike in constrictive pericarditis. However, equalization of diastolic pressure is uncommon. Now, another thing I forgot to mention was that one of the differentiating factors between restrictive cardiomyopathy and constrictive pericarditis is that when we look at the probably, I'm not sure if I have the picture. Okay, yes. So this is one of the ways to differentiate between restrictive cardiomyopathy and constrictive pericarditis. They both have this square root sign, but one thing you know is that the tracing that is above is actually that of the left ventricle, which is telling us about the left ventricular pressure. Then the tracing that is below for both is actually the right ventricular pressure. Now, if you notice that at expiration, during expiration, that's EXP, the pressure within the right ventricle and the left ventricle actually rises up at the same time. But in inspiration, the restrictive cardiomyopathy, during inspiration, there is no drop in the left ventricular pressure. But when it comes to the constrictive pericarditis, you have a drop in the left ventricular pressure, which is, if you look at that tracing, the third one shows that there is a drop during inspiration, which is one of the differentiating factors for restrictive cardiomyopathy and constrictive pericarditis. Now, let me just go back. Now, this is just a TCE showing by atrial enlargement, and then with actually very obvious interventricular wall thickening there. Okay. Now one could also do endomyocardial biopsy, and majorly what it will demonstrate is just non-specific findings, which you have myocyte hypertrophy, interstitial fibrosis, and sometimes, not commonly, you have endocardial fibrosis. Now, the survival rate from time of diagnosis is about 64% at 5 years, and then 37% at 10 years. And most deaths are associated with cardiac causes, either suddenly, like they could have sudden cardiac death, or secondary to heart failure. And a third could actually die of non-cardiac causes, which is actually related to progressive age. Now, I think I talked about the differential diagnosis as listed earlier, infiltrative cardiomyopathies like amyloidosis and so on. Then for treatment of idiopathic restrictive cardiomyopathy is generally limited to medical treatment, emphasizing judicial use of diuretics. And in some selected advanced cases, cardiac calculation if performed, has been shown to be to have similar outcome with other forms of different types, other types of cardiomyopathy aside the restrictive cardiomyopathy. I'd like to go to talk briefly about the endomyocardial diseases. these are also, they are one of the causes of obliterative cardiomyopathies, and they actually include the endomyocardial fibrosis and then the hypereosinophilic syndrome, where low-flying endocarditis is seen. They actually share similar pathologic features and are characterized by intense eosinophilia and thromboembolic phenomena. Now, for was first described in Uganda, as I said, was tropical endocardial disease or endocardial fibroelastosis, and it's said to be probably the most common cause of restrictive cardiomyopathy worldwide. It's prevalent in the tropical regions of Africa, in Asia, Southern America, but it's very rare. It's a rare disease in North America. But whereas for low-flying endocarditis, that one is very prevalent in the northern part of America. Now, EMF accounts for about 10 to 20% of deaths from heart failure in Africa. Now, in contrast to that, HES is seen mainly in countries with a temperate climate. Now, currently, no specific data on gender predisposition, although some there have been mixed findings on studies on gender distribution, but generally, there is no consensus that the EMF is commoner in one gender than the other. Now, EMF mainly affects young adults of lower socioeconomic status. And a study in Uganda indicated a bimodal peak. That's at 10 years and then at 30 years. Now, the exact etiology of EMF and pathogenesis is unknown, but it's said to resemble conditions such as eosinophilic cardiomyopathies and HES. Now, EMF could actually affect both ventricles in about 50% of cases. Then about 40% is only the left ventricle is affected, and then right ventricle only in 10%. Now, the hallmark characteristic of EMF is a fibrotic obliteration of the affected ventricle. And then the underlying process produces focal or diffuse endocardial thickening and fibrosis, which leads to the restrictive physiology. Typically involves the apex of that's the apex of both the left ventricle and right ventricle. And then for the left ventricle, the apex and the posterior mitral valve are usually affected, whereas the anterior mitral valve and then left ventricular outflow tract are actually spared. Sometimes when the papillary muscles are affected, condensed, then you could have a mitral regurgitation and tracheostomy regurgitation ensuing. Then in advanced stages, endocardial calcific deposit and thrombus formation can actually occur. Then coronary artery obstruction are uncommon. And then in them, you have no involvement of extracardiac organs, in contrast to that seen in cardiac sarcoidosis and amyloidosis. Now, I talked earlier that the etiology is unknown, but there are some factors that are being proposed. One is talking about the eosinophilia, the infections, but these have not been validated. They are just possibilities. We have eosinophilia, infections, environmental exposure, talking about the serum, then immunologic, anti-myosin antibodies, which have been detected in some patients with EMF, although it's not specific, can be caused by some other condition. Then could also have some genetic or familiar component, but this currently is actually unclear. Now, how do they present? Because of the affectation of either the left or the right or both ventricles, they could present with heart failure. Then I'll just talk briefly about, there are some phases, 3 phases for EMF. We have the literature, I think I saw 4 phases, but the one that's universally accepted is out of the 3 phases. You have the acute, and then the subacute, and then the chronic. Now, when for the acute phase, majorly you have the febrile illness, and during the acute phase, patient could have fever, they could have heart failure, they will come in cardiogenic shock. Then when the right ventricle is actually involved, they could have the giant V waves. Then also they could have features of pulmonary hypertension, and the presence of 3rd or 4th heart sound or a gallop breathing. Then for investigation of EMF, when you try to investigate for ECG, one could have a low voltage KRS complex and then non-specific ST T-wave abnormalities. Then when the left side is actually affected, could have left atrial enlargement and then atrial arrhythmias, especially in the advanced form. Now, echo is actually the diagnostic tool of choice. Then the pathologic hallmark that is seen on echo is actually apical obliteration and endocardiac surface thrombi. Then other findings on echo could be restrictive filling pattern, whereby the mitral, the E over A is greater than 2. Then could have tricuspid regurgitation, mitral regurgitation, spontaneous echo contrast. Then the atrium, both atria could actually be dilated. Chest X-ray could show cardiomegaly. Then cardiac MRI may show myocardial fibrosis on late gadolinium enhancement. Then Fook-Lockhart eosinophilia may be present. Then hypoalbuminemia also may be present. Now, medical management remains very challenging, as between a third and a half with advanced disease actually die within 2 years. So the prognosis is actually very poor. And one of the poor prognostic factors is that of the presence of atrial fibrillation. Guideline-directed medical therapy for heart failure is very essential. Then oral anticoagulation to prevent thrombotic events. And then immunosuppressive therapy has been used, but it has a limited role, especially in the advanced stage. Then surgery could actually be offered, especially, which is the commonly offered one is the endocardiectomy, plus you can have a valve replacement because of the affectation of either the tricuspid valve or the mitral valve. And this is said to help to improve survival, especially in those with advanced heart failure. Then mortality post-surgery can be up to 15 to 20%. I'll just go briefly to Leo-Flash endocarditis, which is actually the other one under the endomyocardial diseases. The cause, now it said that the cause of eosinophilia in Leo-Flash endocarditis could include known and then idiopathic causes. And this is said to range from helmintic, parasitic infection, malignancy, carcinoma, eosinophilic leukemia, and said that all these conditions are associated with eosinophilia as well as idiopathic hypereosinophilia syndrome. Now, when we're talking about hypereosinophilia, what does it mean? It actually means that you have a chronic absolute eosinophil count month or a pathologic evidence of hypereosinophilic tissue invasion. And sometimes the eosinophilia could also be, in some cases, could be more persisting, could be said to be persisting for more than 6 months or longer, and this is said to be also be common. And then for hypereosinophilic syndrome, it's been linked to a particular gene, this 5q31 to q33, which is inherited dominant fashion. Now, endocarditis, we have, I think, about 3 stages. And the eosinophilic and meditative, and then the fibrotic stage. Now, in the acute phase, these symptoms and the major findings on echo, and echo could just be a normal echo finding. But when one carries out a gadolinium enhanced cardiac magnetic resonance, it can actually dictate the disease. And then some biomarkers may actually be elevated to some varying degrees. Now, in the second phase, which is the subacute phase, thrombus could actually be found in the apices of the affected myocardium, and symptoms could range from either chest pain to dyspnea, and then also some other evidence of disease could affectation of the mitral valves or tricuspid valve, leading to the regurgitation. Then could have cardiomegaly, heart failure, just TV version. And then imaging will actually reveal a mural thrombus, because this stage is actually characterized by thrombus formation. The third stage is actually the fibrotic stage. And then this stage is actually endocardial fibrosis. Then valve leaflet scarring could also occur in this third stage of low flares. Now, the treatment for low flares endocarditis. Now, if the disease is identified at the first stage, because the first stage is just majorly inflammation, if therapies is said that it could if it's picked at the first stage, and then benefits when actually used during the first stage. Now, but in the by the time it gets to the chronic phase, cardiac surgery is actually offered, where you have endocardiectomy with or without valve repair or replacement, and this is done in experienced centers. Heart transplantation remains an option, especially for those with advanced heart failure. Now, going to the next one, talking about sarcoid cardiomyopathy. That's this sarcoidosis is actually disorder of unknown cause, characterized histologically by non-caseating granulomas. This disease is most commonly seen in the Black population and is more common in women than in men. And sarcoid has a very of rising from either the left or the right ventricle. Now, sudden cardiac death is almost always associated with autopsy. Then also a rare manifestation myocarditis, which is actually characterized by high degree AV block, malignant ventricular arrhythmia, and heart. It's difficult to distinguish giant cell myocarditis unless systemic features of sarcoid are also present. Whereas in the case of giant cell myocarditis, the other systemic manifestation as seen in sarcoidosis would actually be absent. Some of the investigations that could also be done, ESR may be elevated but non-specific. Then we'll check for calcium, could have hypercalcemia. Then the serum angiotensin converting enzyme may actually be elevated, but it's said to be seen in some normal population, so there could be variation. So when we do cardiac MRI, that's delayed gadolinium enhancement, may actually show a non-transmural, and then with affectation of the basal or the mid-ventricular septum. Now, the 18-fluorodeoxyglucose positron emission tomography scan is said to complement cardiac MRI in patients with sarcoidosis. And then what does it reveal? It just shows an areas of inflammation in active disease, and then also helps to monitor response to therapy. And then this FDG PET scanning is becoming an important tool for the diagnosis and management of cardiac sarcoidosis. Now, also part of the investigation, endomyocardial biopsy could actually show a non-caseating granulomas, and this is said to be diagnostic of sarcoidosis. That's after a Janssen myocarditis has been ruled out. Now, management of heart failure is very important. Then steroid therapy may be given, especially those that are just newly diagnosed with systolic dysfunction. Then a patient could also benefit from pacemaker, especially when there is high-grade AV block, or there's spontaneous sustained ventricular arrhythmias, or when the left ventricular ejection fraction is less than or equal to 35%, or there is a prior cardiac arrest. This is said to be a class 1 indication to actually give a pacemaker or or ICD. Then cardiac transplantation could also be offered. Now, going to cardiac amyloidosis. This is the most important of the infiltrative type of restrictive cardiomyopathy. So when we talk about infiltrative type of restrictive cardiomyopathy, is synonymous to cardiac amyloidosis. And over 95% of cases are caused by deposition of either immunoglobulin light chains in plasma cell dyscrasias, that's the AL type, or the transthyretin fibrils, that's the ATTR amyloidosis. So there are two subtypes of the ATTR amyloidosis, where we have the ATTRM and the ATTRWT. For the ATTRM, it occurs is genetically mediated as a result of genetically mediated transthyretin tetramer instabilities, and this is said to be infrequent in Europe. Whereas for the other subtype, which is the ATTRWT, that's as a result of age-related transthyretin overproduction. This is said to be more prevalent as compared to the other subtype of the ATTRM. Now, aside the cardiac infiltration that is seen in cardiac amyloidosis, now the amyloid could also have a direct toxic effect on the cardiac cells. And cardiac amyloidosis is characterized by having a patient present with heart failure, either with a preserved or mildly reduced ejection fraction, and is frequently associated with atrial fibrillation, conduction abnormalities. Then could be intracardiac thrombus, especially in the AL type of amyloidosis. Then some patients with cardiac amyloidosis are often resistant to conventional heart failure treatment. Then, however, with a timely diagnosis, admission of targeted treatment in both types of cardiac amyloidosis can improve outcome. Now, for the AL type, now it's very important that a multidisciplinary collaboration between cardiologists and hematologists also is very important, and as a result of the benefit of the monitoring of the available treatments, which actually include chemotherapy as well as administration of high dose of mephalan, and then autologous stem cell transplantation. Now, for the ATTR type, there are actually currently two targeted treatment strategies which have been proven effective in the phase 3 clinical trials. We have one, that's the stabilization of transthyretin precursor protein with the use of tafamidis. So these have been shown to be of benefit. Then the second proven targeted treatment in phase 3 clinical trials is the knocking down production of the precursor protein, either through the gene slicing techniques with small interfering RNAs using the patisiran and vutrisiran. And then you could also use antisense oligonucleotides, that's inotesan, or with targeted in vivo gene editing technique. Now, it's noteworthy that this treatment targets the precursor protein and not the already formed and accumulated amyloid and in the heart. Now, I would like to state that tafamidis is currently the only approved treatment for patients with New York functional heart class 1 to 2 and cardiac amyloidosis, either with the subtype ATTR-WT or ATTR-M without polyneuropathy. Now, the ESC guidelines suggest the use of tafamidis in patients with NYHA class 1 without explicitly addressing the use of patients with NYHA class 3, who showed less convincing results in the ATTR ACT trial in terms of hospitalizations. Now, heart and liver transplantation can be considered in some patients with advanced cardiac amyloidosis of the ATTR M type without severe neuropathy. Now I talked about the, we also have restrictive cardiomyopathy occurring as a result of radiation. So the radiation, which is termed the radiation-associated restrictive cardiomyopathy, this develop as a consequence of radiation exposure for treatment of malignant disorder, usually with a latent period of 5 to 10 years. So, it's also very important as part of our evaluation to take history of probably treatment for any form of cancer with the use of radiotherapy. It's also very important. And how does it cause it? How does radiation lead to cardiomyopathy? Radiation actually induces inflammation. There's microvascular damage, myocardial capillary function, which leads to ischemia, necrosis, and diffuse replacement fibrosis. Currently, there are no specific therapeutic options available for radiation-associated restrictive cardiomyopathy. So the treatment should just follow the general principles of heart failure management. And then in some selected patients with advanced heart failure, heart transplantation can actually be considered. Now, we also have the storage disorders associated with restrictive cardiomyopathy. Now, this is a particular form of restrictive cardiomyopathy which is caused by intracellular accumulation of metabolites causing the myocardial damage, and is mainly caused by inborn errors of metabolism, except for some other types of ion overload. Now, some of the examples of storage disease include that of lysosomal storage disease, Anderson fibrin disease, mucopolysaccharidosis, glycogen storage disease like Danon disease, Pompe disease, Corey disease, and then the PRKAG2 cardiomyopathy. Now, some of the clinical manifestations could actually include electrophysiological changes, like in the case of conduction abnormalities, and or it could also be affectation of the valves. Now, targeted therapies have been developed for several inborn errors of metabolism, especially in the case of Anderson fibrin disease, where there is deficiency of the alpha-galactosidase A. This can actually be corrected by the replacement of the enzyme named galactosidase alpha or beta, and this is said to lead to improved prognosis. Now, at the cardiac level, treatment is particularly effective if started before the development of irreversible fibrotic changes. Then an alternative is actually the drug called megasatat, which has been shown to stabilize and especially in those. It also helps to reduce the cardiac mass in Anderson fibrin patients. Then such treatment is approved in patients with amenable mutations in one of the syntheses of functional but misfolded enzyme is actually preserved. Now, we could also have, I think I've talked about the mucopolysaccharidosis. Now, iron overload associated restrictive cardiomyopathy. We can have an iron overload cardiomyopathy. Can be caused by hereditary hemochromatosis or could be secondary to iron overload, either from repeated blood transfusion or in patients with ineffective erythropoiesis, like in patients with hemoglobinopathies, thalassemia, sickle cell anemia. And then in either of them, one thing we notice that the iron binding capacity of transferrin is actually very high, and which makes iron to be deposited in various organs, like the liver, the endocrine organs, the skin, joint, including the heart. And so when there's iron overload restrictive cardiomyopathy, there could be conduction abnormalities, and there's increased risk of supraventricular arrhythmias. Example, atrial fibrillation, and then ventricular arrhythmias and sudden cardiac death is also very high in them. And sometimes the iron overload cardiomyopathy may actually start initially as restrictive cardiomyopathy, but as it evolves or progresses, then there could be features. At the later stage, you could have features of dilated cardiomyopathy. Now, when you have serum ferritin levels greater than 300 nanogram per mil in males or greater than 200 nanogram per mil in females, and transferrin transferrin saturation greater than 45%, this should prompt further diagnostic assessment in any patient that has this, for one to suspect possibility of an iron overload associated cardiomyopathy. Now, cardiac MRI can also be used to quantify the myocardial iron overload. And this is said to inversely correlate with LV, left ventricular ejection fraction. So as the myocardial iron overload, as it increases, then there is worsening of the systolic function. And this myocardial overload, myocardial iron load is said to predict development of a heart failure. So that means when you have a very low myocardial load, then that means the ejection fraction is likely to be preserved. But when there is increased iron load within the myocardium, that could actually prognosticate possibility of having a very poor ejection fraction. Majorly, the mainstay of treatment is actually therapeutic phlebotomy, especially in those that are not, that don't have anemia and hemodynamically stable patients. Now, for those that actually have anemia, one could actually do use ion chelation therapies for those where you can use deferoxamine or oral deferriprone can be used in them, especially for those with severe heart failure or anemia. Now, I'll just go briefly to carcinoid heart disease. Carcinoid heart disease is a rare condition that occurs as part of carcinoid syndrome. And carcinoid syndrome is a systemic disorder mediated by elevated circulating levels of vasoactive substance. That's including the serotonin, 5-hydroxytryptan, histamines, bradykinin, and then the tachykinins and prostaglandins, which are produced by rare metastatic neuroendocrine malignancy called carcinoid. Now, carcinoid syndrome is characterized by a triad, which is the flushing triad of symptoms: flushing, diarrhea, and Broca's spasm. And this can occur in association with hepatic metastasis. Now, carcinoid heart disease has also been rarely described in association with non-metastatic ovarian cancer. That's carcinoid heart disease associated with non-metastatic ovarian cancer. How would patients with carcinoid heart disease present? They could present with symptoms of right heart failure, or they could present with symptoms of right heart failure, pedal edema, raised jugular venous pressure, and so on. And then when you have elevation of the urine 5-HIAA level, it's said to be specific and moderately sensitive for diagnosis of carcinoid syndrome. Then echocardiographic and cardiac magnetic resonance features of thickened immobile tricuspid and pulmonary valves with combined stenosis and regurgitant lesions are highly suggestive of cardiac carcinoid heart disease. Now, therapy is not generally curative; it's just majorly supportive. But one could actually do debulking, and then with the use of partial hepatic resection and the use of octreotide, which is a somatostatin analog. Newer therapy includes radiation therapy, delivered by peptide receptor-linked radiotherapy. So radiotherapy could actually be used in carcinoid heart disease. I think that's the end of my slide. Thank you so much for listening.
Well, thank you very much for a very, very extensive presentation. I think you've done well to go ahead and cover the individual etiologies of restrictive cardiomyopathy, which is good, because we also have some other people who will be taking these topics again individually. So to just serve to reinforce the knowledge. Thank you so much, Dr. Olalekan. Yeah, just a few comments. With the endomyocardial fibrosis in the tropics. So before now, it was really thought that it is a sort of late complication of hypereosinophilia secondary to heavy parasitic infestation. Okay, which is thought to be similar to the low-flash syndrome. But however, you know, recent studies among people in the tropics with endomyocardial fibrosis, you know, have not shown any relationship with parasitic infection. The only thing that is that parasitic infection are endemic in the tropics, but they've not been shown to be a causative agent for endomyocardial fibrosis. And in fact, in this patient, they've shown that they do not have hypereosinophilia at all, the people with tropical endomyocardial fibrosis. They tend to have normal eosinophil level. So the cause is still idiopathic, largely unknown. Okay. And then another challenging thing that you get, especially with patients with amyloidosis, you know, the amyloid deposit generally starts from the endocardium, the subendocardium, and then spread to the myocardium, okay, like outwards, from the inner part outwards. Now, as you mentioned, they are prone to having conduction abnormalities, and they can get complete heart block. You know, when you get a complete heart block in a patient with cardiac amyloidosis and you have to put in a pacemaker, it's actually a nightmare, because you can go with your lead and then anywhere you put it around the apex, you are not getting capture, because most of it is just amyloid deposits. You are not getting good contact with the myocardium. And sometimes you just manage to get capture, but with very high threshold that can run the battery down in 2 to 3 years, something that's supposed to last between, you know, 7 to 15 years. So when you have people with endomyocardial, with amyloid, who are very thick myocardium with large amount of deposit of amyloid, if they do develop complete heart block, it's a serious challenge putting them on pacemaker. Okay. The other thing I want to just get some clarification from you is anticoagulation in patients with idiopathic restrictive cardiomyopathy. So if such patient with idiopathic restrictive cardiomyopathy develop atrial fibrillation, do you anticoagulate them generally, or do you base the use of anticoagulation on the Church-Vass score? Okay, you know, like for instance, in hypertrophic cardiomyopathy, once you have atrial fibrillation, you don't ask for Church-Vass. You just anticoagulate, because the hypertrophic cardiomyopathy poses a high risk for stroke, cardioembolic stroke. So is that the same with idiopathic restrictive cardiomyopathy, or do you have to use the Church-Vass score? And then also, secondly, still on the anticoagulation, when you are talking about the pathophysiology of low flash, you mentioned that apical thrombus formation is part of the pathophysiology together with the endomyocardial thickening. So in that group of low flash syndrome, do you then anticoagulate all of them, or it's only when they have arrhythmia that you have to anticoagulate, since apical thrombosis is part of the pathophysiology in those patients? Okay, so those are the comments and questions that I have. Dr. Olale.
I can hear you here. Thank you, Dr. Conte. Now, I think looking at the first question you asked about whether to anticoagulate or I'll do the Church-Vass score for a patient with idiopathic and restrictive cardiomyopathy. I think looking at the Church-Vass score, I think is actually used for a non-valvular atrial fibrillation. So yes, if there's patient idiopathic, because I know that for idiopathic restrictive cardiomyopathy, they do not present with, they don't have, they do not usually present with atrial arrhythmias as compared to that of the infiltrative type, which is the amyloidosis and sarcoidosis. Those are the ones that you have more of the atrial arrhythmias. But in case idiopathic restrictive cardiomyopathy present with atrial fibrillation and then there is valvular involvement, then I would like to do the Charles-Vac score before I actually anticoagulate. Except there are other compelling reasons. Probably there's a clot within, because the major findings on the echo is actually the bilateral, very large right left atrium. So if there are spontaneous echo contrast, I don't think I want to wait till when I do the Charles-Vac but to prevent, because one of the complications is actually thromboembolism. So I would like to actually anticoagulate them.
Okay.
For that.
Hello, sorry, if I may come in there. If you have a patient with amyloidosis and atrial fibrillation, you don't need any Charles-Vac score. You have to give anticoagulant immediately, irrespective of the Charles-Vac score of the patient. It's the same with hypertrophic cardiomyopathy.
Okay.
That's just what I want to add.
Okay, thank you. Then, Dr. Olaleka, about low flares, do you anticoagulate generally based on, because in the pathophysiology, you mentioned that they develop apical thrombi.
I talked about, there are talked about 3 stages. You could have this acute, intermediate, and the fibrotic stage. The intermediate stage, which is actually the second stage, is where they have thrombus, which is actually seen in the apices of either the both ventricle. I think because of the embolism associated with this, I wouldn't wait to have a Charles-Vac, so I will anticoagulate them to actually prevent embolism to the brain and other organs, which could actually be the first presentation in patient with low flares or endocarditis.
Okay. Okay, so the floor is open. Anybody else who has contribution or questions to ask? While we wait, I'll be reading the comments on the chat. Okay, yeah, Dr. Florence is saying, great job, Dr. Lalekan. Dr. Aldeji Stephen is also saying, thank you for a lucid and extensive presentation. Any questions from colleagues? Okay, I think we can take comments from our chiefs. I think we have the Chief Adeyanju with us. Chief Adeyanju, if you can unmute and comment on the presentation. Dr. Omokorode is also saying thank you for a brilliant presentation. It seems as if Chief Adeyanju is not with us. Dr. Cyril, any comments on important areas to focus on in this extensive presentation? Dr. Cyril, we can't hear you. Okay. Okay, Dr. Ojo. Dr. Ojo, if we can get some comments on you about important areas to focus on in this topic. Hello, hey, is everybody asleep?
It's possible. I think it's already very possible.
Shall we? Okay. All right. So anyway, since other chiefs are not around, so in the absence of any further contribution or question, we want to once again say thank you very much to you, Dr. Olalekan, for this extensive presentation. So today's Friday, so we're having this weekend, we don't have anything scheduled yet, but hopefully by next weekend, we want to start taking the guidelines. Hopefully, we're going to work on that to see. It's been difficult getting the chiefs to do that for us, so we might have to, start taking them ourselves. I'm happy that some people have volunteered to take some of the topics. So let's start preparing so that by next weekend we start looking at the guidelines. Also, the people who have not been able to take their part in the MCQs, we are appealing that you please, try not to default. And now I see Dr. Florence has already posted, we have to resort back to doing backups. Please, let's try, to do our part so that together, we can go through this discussion and go through the exams. I think that's all from me. Florence, if you have any announcement to make.
Okay. I just want to thank Dr. Olalekan for an extensive presentation. And those of them who took their part in their MCQs, I want to say thank you to them. We appreciate their efforts. Our seniors also, Dr. Adeyanju, for always being around, and every other person present. I want to say thank you. Please, let's keep pushing. Let's not relent. It's not over until it is over. Thank you. That's all I have to say till we meet again on Monday. Thank you. All right. Good night, everyone. Thank you.
Thank you all.
Chief, you're awake. Dr. Adeyanju is awake.
Oh.
All right then. Dr. Adeyanju.
Hello, Dr. Florence. Hello, everyone. Well done.
Thank you. Thank you so much. We appreciate you. Thank you.
Sorry, I was multitasking.
Yeah. Okay, that's fine. It's allowed. Thank you. Good night, everyone. Good night.